So let's say now you're in an acute care setting. How do things change? Let's say that same COPD man, you're now in acute care. Anything change? What activities do you anticipate them being able to do? What you got? Now they're in acute care, so they're compromised.
I would imagine they would have difficulty just walking, so like the only thing they'd probably really do is supine to sitting would probably.
Okay, there you go. Start with the bed mobility. You got to get them up. You got to be able to roll over. They've got to be able to change linens to get to them and all that kind of thing. So start with bed mobility, first and foremost. All right. Where do we go from there? Walk where? Just within the room. Yep. To the recliner and back. Sit to stand. To the restroom. Okay. All of that is totally legit, billable, and functional. All right. So now they've been there a couple days and they're doing better with all that type of thing. You come in about the day they're getting ready to discharge. What are you doing? Lots of patient education. What are you going to tell them though? All that stuff we just said for.
Here's how you continue that. Be aware.
Okay. You got somebody in an acute care setting, if they're going home, you might want to take them amongst the hospital. If they've got stairs they've got to deal with at home, you got stairs in the hospital to go deal with. If they want to be able to go outside and walk on their grass, whatever, take them outside and walk on their grass.
Watch them transfer themselves.
Absolutely. You've got to make sure you check the boxes. Because they go home and they haven't done those things, they're going to fall and they're going to be back in there with a hip replacement. Acute care is not that much different. You just got IV poles and things like that to worry about. All right, so this talks a little bit about indications for mobilization, talking about our lungs a little bit. We're not going to get too much into the pulmonary aspect. We're not going to have time to cover all that, so we'll do that in the fall. But this just touches on it a little bit. Acute conditions that are indications for mobilization and exercise. We got somebody that hypoventilates, that does not get enough air. Consolidation, infiltrates, inflammation, pleural effusions. What's a pleural effusion? Build up around the lungs, exactly. Yep. Yep. You heard the term pleurisy before? Yep. Acute lung injury and pulmonary edema. Contraindications and precautions to exercise for these folks. DVTs, unstable vitals, not able to follow commands, fully sedated. You're gonna see that from time to time too. You'll go in to the hospital room and you've been told to go mobilize this patient, get them up, get them moving, what have you, and they're fully sedated. Have anybody encountered that one yet? Yeah. What do you do about that?
You can do passive range of motion.
You can do some passive range.
But a lot of times it's like, what the heck? Why didn't you tell us he was fully sedated?
Exactly. You can try. Yeah, you can try. But a lot of times they're medically induced and it's not going to happen.
But sometimes the family is in there, so we can like educate.
That's exactly right. Make use of your time. Educate folks. Very good. All right, it's the same thing when you're exercising these folks. Even more so, be aware of the current medications. We didn't talk about that enough in the cardiac because they're all going to be on beta blockers and all kinds of stuff like that. think about how the medication, and I know you're not gonna know all those medications. I don't know all those medications. If you don't know, ask. If you feel like, hey, this is really somebody who's, you know, looks like they're just completely out of it, ask nurse certainty. You get an inpatient, or I mean, excuse me, an outpatient situation, you're gonna have time to look some of those things up, and you need to do that, because you're not gonna know all of them. Same stuff we just talked about. Abnormal responses, we talked about this. Heart rate increases more than 20 to 30 beats per minute above resting heart rate. Again, this is per Met level. So if you just have them go from bed mobility to, say, sit to stand, and their heart rate jumps 40 beats per minute, you gotta scale it back. That's too quick, too soon. Okay? If the heart rate decreases, that's big. That's even more of an indication. Something's really wrong there. If systolic pressure increases 20 to 30, or decreases more than 10, with dizziness, nausea, vomiting, some issues going on there. Okay, O2 sat drops below prescribed level. What's the usual prescribed level for O2 sats in, say, an acute care setting? Again, it depends, I know, but give me a estimate.
95.
Below 95, you're starting to think about stuff. I would say probably about 92 is when you need to say, okay, we gotta do something different. They need some supplemental oxygen, or we need to just scale things back, or what have you. Okay. You get somebody at 88, they're probably blue. Right? Certainly not gonna exercise somebody there. Shortness of breath, again, it's something you can ask them. We talked about ECG changes, chest pain, definitely not going to do anything there. Agitation, how do you deal with that?
As best
Yes, ma'am.
we can.
This is not.
I got you.
Okay.
I got you.
So if someone has like COPD,
Yep.
what is your rule of thumb for when you would stop exercising them? Because I know like the exercise is just lower in general.
Yeah, I think you just have to look at it from a grand scheme of things. Look at them. How are they breathing? Ask them their RPE scale, as well as a dyspnea scale. Get their assessment. Then you're looking at their vitals as well. A lot of these people don't want to be pushed. That's your job. You have to push them. But how much is too much? It's going to be case by case. And I think, you know, as students, if you're in that setting, that's when you really lean on CIs to say, hey, how are we doing here? Do we need to push this person? They're going to tell you yes or no. Because that's their license on the line. They're not going to let you overdo somebody by any means. Somebody else had a hand up.
Yeah, it was the same question.
Yeah, same kind of thing. Okay. Oh, how are we going to deal with the agitated person?
Make them know that you're trying to help them and not hurt them.
Some empathy. Yes. Yes. It's a good way to put it. You know, we don't simulate that enough in here. If you have Rebecca as a,
Oh my
They're my
gosh.
favorite people.
she can be agitated. No, it's good. It really, you have to work through some of that kind of stuff, because people are going to tell you all kinds of things. Here's some normal values. Definitely want to know these. These are pretty wide too, aren't they? I mean, look at this. How many people do you know with a systolic blood pressure at 85? That seems really, really low. Probably pretty lethargic. My mother-in-law's is like usually 98, stuff like that. She can be. Functional mobility, we talked about that, getting them up, getting them moving, transfers, using assistive devices. How many of you guys have dealt with that already? Somebody has an assistive device that they bring with them to therapy or they have in the hospital, and it's totally inappropriate. It's fitted wrong. They may need something that's more supportive, less supportive. That's your job. Fix it. Fix it. Yeah.
Yeah, like we had a patient. She was using a cane that was her dad's old
Mhm.
cane, and it was way off center. Like when she was walking, it was like above her like this.
Yeah.
And she was like, "Oh, but it's just not comfortable for us." And we're like, "I mean, yeah, because it's not fitted for
Adjust
her."
it.
Yeah.
Yep. Yep. And tell them why. Tell them, because a lot of these people are sentimental about some of that stuff. Hey, this is what my father had it at, or
Well, it's like
whatever.
a wooden cane.
Yeah,
Like,
wooden
you couldn't
cane,
adjust
yeah.
it.
Tell them it's not, that's wonderful. Keep it as a family heirloom, not appropriate.
That's the same kind of
Yeah.
thing. We had a lady come in and she had a wooden cane she bought from some guy, and it was like bowing out real bad, like it was not gonna support her weight.
Right.
Scary.
I had the lady with the rollator, and she said that, my husband used this. Now this lady, try to be nice here. Her backside, if she turned around and sat on that rollator, this was not gonna end well. So that's a really hard conversation to have. I mean, what do you say to this woman? Tell me, Jasmine, what do you say to this woman?
I don't even know how to approach it, because if she's a woman, so you don't want to say
Correct.
she's too big, because then that's gonna go completely left.
This is just a not appropriate device for you.
Yeah,
It
man,
does
let's
not
just
fit
fit it for your
you.
husband, not
I
for
Yeah.
you.
just don't
Let's
fit
try to
you.
work on
Maybe
getting
we
you
should
something
get
fitted.
one a little bit cuter for you.
Cuter.
Maybe the husband's was red, and get her pink one.
We could get her some bedazzled stuff on
Stickers or
it.
something,
Yeah,
yeah.
stickers.
I think we should dazzle this up. I don't think
Sounds
this is
good.
for you.
So how do we go about changing that for them though? Just tell them
I
that they
just
need to change
tell
it?
you.
I would usually, if that was the case, I would talk to a family member first. Because a family member probably knows this. But maybe sometimes you have to be the bad guy on it too.
Just go to the PT and tell them to do it.
Yeah.
True,
And
too.
I just refer me to you.
True, too.
That's what they're for.
I'll make that your job.
Why don't you tell them?
It's all the place here.
How about these? Boy, these are fun, aren't they?
What is it?
Never seen one of those?
Yeah,
Oh.
they're terrible.
Got all kinds of bells, whistles, lines, open gowns. There's so many bad things about this. Oh, so glad I don't do that.
I don't think a lot of people have that one though specifically. They use all different, they have to drag all the other stuff with them.
Yeah,
The original
that's even
stuff.
harder.
It's not very fun.
Obviously, safety is paramount. Equipment is really, it's a tricky little deal, because you've got to look like the expert, but you might not know the first thing about what you're dealing with. So that's when you want to lean on somebody that's got more experience. There's nothing wrong with asking a question about something like that. As a CI, I would want you to do that. Do not be afraid to ask questions. Patient education, you guys have touched on this already. Not just the patient, caregivers, family members, okay? Maybe even other medical personnel that you have interaction with. If you've got somebody, OTs are usually really good. Nursing's usually multitaskers. But somebody like dietary or something comes in, nutrition people come in, they don't have a clue about what we're doing. Zero. And they may put somebody in the chair that doesn't need to be in the chair. You gotta be firm, but be respectful and let them know, hey, this is why we're doing this, okay? Yeah, I mean, patient education is saying all these things that it does. Increases the patient's participation as an active member of the healthcare team. I think it gives them some skin in the game there. People want to have some independence and some control, okay? If you can educate them on how to do some of these things, that gives them some of that, okay? Think about that. 3 factors contribute to non-compliance. Barriers that patients perceive. Give me an example of a barrier. What's that? Language barrier. What else?
Cognitive barrier.
Financial barrier. The one lady that has the old cane, she might not be able to afford it. Okay? That's when you can be an advocate. If you can document the need for that, insurance will pay for that. Lack of positive feedback. Give good feedback. When someone does something, please praise them. Perceived helplessness. That's when they just give up. Okay? Happens all the time. Happens all the time. How do you evaluate the effectiveness of an education program?
Making
See
sure
how much they
like,
learn.
Yeah, ask the patient.
But how do you document that?
Patient was able to
Test
recite this, understood, you know,
Okay.
the
You can-
explanation.
Yeah, you can have it as a goal. You know, they've got to be independent with X, Y, and Z, and demonstrate that. I've had goals where they had to demonstrate something to a family member. The other thing that you can do too with the effectiveness of education programs, especially maybe more in an outpatient setting, is surveys. You guys have the ability to say at the end of someone's discharge, hey, do you mind filling out this survey on what we did with you following your total hip replacement? They're usually pretty welcoming to do that. Your facility may do that, but encourage that. Encourage that participation. That's how you get to know about these things. Discharge planning, huge, especially in acute care. Again, just like we talked about, try to simulate things at home, work with discharge planners. You're gonna have multidisciplinary meetings where you go and you talk about people and you say, okay, this person's ready to go, but they're gonna need some rehab. So they're gonna need either go to a rehab setting, an inpatient rehab setting, or outpatient or home health. You will have a stake in that. You will let them know what your opinion is. That's important. Involved in securing durable medical equipment. Yes, just like we said, be an advocate for your people, okay? Anybody got to go to these meetings yet? Not many of y'all are in acute care. Did you have one up at Russell?
I did several.
Yeah. Pretty interesting to get everybody's perspective on all these types of things.
Yeah.
Yes. It's good to see collaboration amongst the healthcare team. Systemic effects of immobilization. Gosh, you've seen this before, right? Conditions associated with acute cardiopulmonary dysfunction. All right, so this kind of summarizes what Vicky's presentation was talking about. Primary prevention, cardiac rehab. Active intervention for those risk factors that cause cardiovascular disease, the things that we talked about earlier. Candidates, those who are at moderate or high risk, do that coronary risk stratification. The need, if they've got the more risk factors they have, the greater need they have. Therefore, they're a better candidate for this. Get them in. Compliance and lack of payment. Again, I said this earlier. someone who's had a cardiac event, compliance is not a problem for the most part. They are scared to death, and they will be very compliant. Lack of payment for services, if you can justify the need and prove that they're a good candidate, that's usually not a problem. Insurance would much rather pay for cardiac rehab than someone to have an MI. Again, risk factors, we already talked about all those. We've talked about these. Again, if you're in phase 1, they're gonna get dietary counseling inpatient. They will get some type of stress management, some type of handout things, and I've got a bunch of handouts in Canvas. Sternal precautions, you see that handout that's in there? Make sure you guys review those things, okay? I'm not gonna sit there and read those things to you. They're very much common sense. Smoking cessation, if they are smokers, they will get plenty of education about that. Obviously, inpatient, they'll get pharmacological management. And again, we talked about patient education. Looking at specifics for hypertension, weight management, and dietary. Again, I think this is common sense stuff here. Okay? Just make sure you guys have at least a view of that. Primary prevention, we talked about bed rest and all the negative aspects for that. Get them up and moving. Excuse me. All different types of centers that you're gonna see for primary prevention. Rehab programs will be multidisciplinary. What are you gonna see in cardiac rehab? Yes, sir.
I was just curious, so like in the cardiac rehab, how many did you see that didn't have an MI, or was just there because they had?
No, there are quite a few, quite a few. You'll see people with congestive heart failure. You'll see people with arrhythmias. I would say where I was at, less than half had an MI. It's probably 60% that just had other things going on too. What other disciplines will you see? I mentioned a few of them in cardiac rehab.
For like daily.
You won't see speech.
Dietitian.
Dietitian, definitely. Now, they may not be there every day. That's gonna be something they come in and do once a week or whatever. What else? Nurse is there 100% of the time. That might not be completely accurate, but for the most part, they're there 100% of the time. What else? You gonna see PT there all the time? Nope. Most likely you're not, because they can hire an exercise physiologist a whole lot cheaper. What else? Lots of texts. Yep.
Would you have a respiratory therapist?
Certainly possible. If you've got a bunch of COPD, emphysema, if you've got that population, I think you will probably see that, yeah. At least for the education component of it. Anything else you can think of? You'll have a medical director. You might not see them, but they're there. Trying to think of anything else. Nutrition we talked about. Sometimes they will have what they call a hospitalist. Have you guys heard that term before? That's a doctor that functions within a hospital system that basically is just kind of the person that puts people in the right place. A hospitalist is going to be someone that does rounds with everybody, refers people out. So if someone needs to be in another setting. They need to be in inpatient rehab versus an acute care setting. The hospitalist might be the person that says, okay, that needs to happen now. You may just see their specialist, whoever they see, a pulmonologist, cardiac, whatever.
So what
But
the
a hospitalist is more of a general sense.
doesn't the hospitalist like take a lot of the patients that don't have a primary
Yeah.
care?
Yeah. And you'll see that a lot of people don't have primary care physicians. A lot of people don't go to the doctor. Yep. Yep. Or they can't afford it, or whatever the case may be. Or they just flat out refuse anyway. All right, so acute care, phase 1. This will occur in acute care. Early mobilization we talked about, well established. Poor candidates. We talked about this earlier. Overt congestive heart failure. If you get somebody who is failing and failing quickly, they're not going to be in cardiac rehab. They're probably going to be in hospice. Unstable angina. Hemodynamic instability. What does that mean? All right, use your med term here.
Something about when you move and something really unstable. And the hemo is like blood, so.
Hemo is blood. So if their blood, whatever, their blood gases, their cholesterol levels, whatever, are unstable, they're not going to be a candidate for something like that. We talked about arrhythmias, conduction deficits, other organ systems. I mean, a lot of these people have comorbidities that go beyond what you can fathom. I've got a case study for you guys tomorrow that will incorporate neuro with cardiac. So, that'll be interesting. Uncontrolled hypertension, gotta get that under control. They'll usually medicate those people to the point that they will fall into compliance there. Activity guidelines, indications, program is modified for persons designated as complicated. Again, lots of comorbidity here, so you've got to be flexible with these types of things. General precautions, there's all kinds of paperwork and stuff that you will have them sign, talk about, all those types of things. Again, the contraindications we've talked about over and over now. There's the contraindications, acute care, keep the instructions simple. Most of these will have, you'll be handing them handouts, they'll have all kinds of handouts. Keep things simple because you don't know the level of education you're dealing with, the cognition, there's all kinds of things to consider there. But education plans should be specific to individual and address the risk factors. So if you've got somebody with that high cholesterol, they may get more dietary stuff than somebody who has arrhythmia. It really doesn't impact, it's not impacted by that. All this good. Audiovisual aids are helpful, agreed. This is an example of day 2, day 3 for discharge. Sitting them up, bedside commode, versus days 3 to 4 where they're walking the halls 3 to 4 times a day, assessing stairs, self-care, all that type of thing before discharge. And it has to be addressed before discharge. Again, we've talked about all of this. Psych and behavioral modification, that's another thing you might see. A lot of times people just have some kind of subspecialty in that. Social workers could be part of it. Outcome measures, that's something you're going to track all the time. But again, you've got a lot of data when it comes to these things, so taking the vitals as much as you do, you've got ways to measure outcomes. And again, discharge, you got to figure out where they're going, how they're going, when they're going. These are some of the outcome measures that you'll use. Phase 2, this will be outpatient. Comprehensive, long-term programs involving medical evaluation, prescribed exercise, cardiac risk factor modification, education, and counseling. Okay? This is the candidacy, this is where they've got to be. Groups that are automatically covered, MI within the last 12 months. What does CABG mean? Coronary artery bypass graft, yes. So if you see the folks that have big scars on the inside of their legs, that means their veins have been stripped and they are now functioning as coronary arteries. They've had bypass most likely. We talked about stable angina. PTCA. Anybody know that one? I'm not sure which one it is. I was hoping you guys would. I don't think it's post-traumatic. I'm guessing.
Percutaneous transluminal coronary angioplasty.
Oh,
That
I was
sounds
gonna do
good.
that one.
Well done, Google.
Google.
Read it again.
Oh God. Percutaneous transluminal coronary angioplasty.
Outstanding. So they go through your skin to bypass your artery. That's amazing. Lung transplant, heart and lung transplant, folks. Automatic. Valve repair, automatic. Home-based cardiac rehab, I haven't seen much of that, to be honest with you. I guess it's certainly a possibility. And I guess PTA could be involved as a home health. These are some of the roles that you're gonna see. We talked about the interdisciplinary approach. So, if smoking is a risk factor, they will get all kinds of literature, get lectured to, they'll make them throw away their cigarettes. Referral to smoking cessation program. Anybody been through smoking cessation or had a patient go through it? Care to share any of that?
I mean, it sucked.
That's exactly what I was saying.
It sucked. It took a long time. Like I went from cigarettes to vaping and then did that for a long time and finally just was able to wean down the nicotine. And
That's what I was gonna say. It's usually a very step down process. So,
And then like you get stressed out and say screw it and go buy another pack of cigarettes.
of course, there's lots of relapses that come
Yep.
with this. Did you do nicotine patches? Nope.
I did the lozenges or the
Yeah.
like pouches, I guess,
Yep.
for a while.
Yep.
But
It sucked. That's exactly right. This is what they're gonna tell you. Obviously, we're in charge of this part. Nutrition and lipid management, that's gonna be through counseling, dietary, all that stuff. But again, we've got to be supportive of this, okay? If they walk into their exercise program holding sausage, egg, and cheese biscuit, which will happen, I promise you. Yes?
And so the one person I want to see applied before, he had an MI in the hospital. The next day, his family was bringing him KFC.
Yep.
And then every day after that, and then finally the nurses had to stop letting them come in because they would just bring McDonald's and all that.
Yeah.
And he
That's
would
incredible.
complain.
It's
Said the
incredible.
food sucked.
You will see amazing things. Amazing things. You will never be bored in that, believe me. Here's one to think about, and I did not think about. Menopausal females with bone density issues, okay? You'll have dietary, but you'll also, we play a role in this too, right? We need to get them weight bearing. Efficacy of cardiac rehab is phenomenal. Decreasing risk factors, improving functional capacity, cardiac efficiency, and decreasing the mortality rate, which is the ultimate goal, obviously. normal responses to exercise.
So is this like more for people who have like a comorbidity after having like an MI? Because like, I remember my granddad had a heart attack.
Yep.
He used to chew tobacco, he like stopped cold turkey, like stopped everything, and I don't remember him really going through like
Not many,
rehab.
I would say,
He was in pretty good shape too.
it's a great question. What percentage of people who have heart attacks go through cardiac
Like
rehab?
what causes them to be like, okay, they'll be fine without rehab versus I feel like they need cardiac
That's a
rehab.
great question. I do not know the answer to that. Part of it's financial, but Medicare covers, that's what I was saying, Medicare covered all those other ones. So if you have an MI, it's more about the one, two. Yeah.
Based it all around how invasive the surgery is, like the fix?
Yeah, I mean, some people don't even have surgery.
Right.
Yeah, it certainly plays a role in it. You know, if you have an MI and you've gotta have several bypasses or what have you, yeah, exactly, an open heart surgery, you're gonna be obviously in the hospital for a lot longer. Therefore, more likelihood of you going through something like this. Yeah. So, how debilitating was your grandfather?
I don't think it was too bad, but
Yeah.
I remember my grandma had one. Hers is pretty rough, and I think she did go
She
through
did, okay.
cardiac rehab.
Yep.
But my granddad, like, he was fine.
Yeah.
He did pretty good.
Now, was he relatively active on his own?
Yeah, he was in pretty good shape.
Good.
at that point.
And that's probably why. You know, if you've got somebody like that, they're medically stable.
The
and
only
willing-
thing he did was chew tobacco, but like, once he had started it, he literally stopped cold turkey. Like, never picked it up again.
Yep.
So,
That's great. It doesn't happen very often though. Upper limits, these are good things to know. These are pretty specific, but, here's our scales. Angina scale of 0 to 4. Dyspnea scale 0 to 4. I've seen it, I see this more as a 0 to 10 scale. These will be posted on the wall of cardiac rehab. Okay. Phase 3, again, outpatient based. Not a lot of people get to this point. This is when insurance starts to get a little bit more problematic.
That's what Vicky does, right?
What's that?
Vicky does this one?
Yes, for the most part. I think she helps with 1 and 2 a little bit, but this is where she's got people that actually come to her, that drive to the hospital. Yeah. Typically around 3 to 4 weeks in duration. I think that's about right. So hopefully it goes phase 1, 3 to 4 days, maybe a week in the hospital. Phase 2, outpatient, usually 4 to 6 weeks. Phase 3, a little bit shorter. And then phase 4 is independence. So this is going ongoing. Fitness centers, senior centers, what have you. Any questions on all that? I know there's a lot of material. We got through here though. Better than I thought.
Will the hospital like tell them that, like tell them they need like cardiac rehab, or will
Yeah.
they have to find this out on their own?
No, they will recommend that. So if they've got a cardiologist or a cardiac surgeon or whoever they're dealing with, they will take those risk factors that we talked about and say, you've got 4 of the 7 risk factors. You're a candidate for this. This is what we want you to do. This is your treatment plan.
Cause like, so if you have a patient who comes in to therapy just for something else, and they could be a good
A
patient.
good candidate for that?
Yeah. Would,
Good.
is that my job to?
Yes, your job to advocate for that? Absolutely. Absolutely. Now, if you've got somebody with neurological problems or severe orthopedic conditions and all that kind of thing, what's more important? You gotta, you know, if they've got minor cardiac issues, again, I hate to even say minor because they seem all to be very important. But major neurological issues, obviously that may take, they may not be able to participate in this because of other things, is what I'm saying. Yeah. But it's a very interesting field. And especially here in the South where we tend to eat poorly, be obese, not real compliant with all these things, I think you're gonna see more and more of this. So if you're interested in it, I think there's opportunity there. All right, we good? All right, so let's start checkoffs at 12:45. That gives you an hour and 15 for lunch. Any questions? All right, carry on.